Hi, my name is Susan Elliott, and I am a nurse practitioner at St. Louis University in the School of Medicine. I work in Division of Geriatric Medicine. Today's presentation is on person-centered care, resident rights, and diet downgrades in post-acute long-term care. Our university does receive funding through HRSA, a GWEP grant or a Geriatric Workforce Enhancement Program grant, and part of my salary is supplemented. The objectives today are to provide an example of an ethical concept relating to diet and post-acute long-term care, determine which residents have the right to refuse a medically prescribed diet, summarize patient-centered care according to guidelines, and to summarize resident rights regarding diet. What is an age-friendly care system? It's one that values what matters most to a patient or a resident, medications, their mentation, and their mobility. So as we move through the talk today, we'll be correlating back to these 4 M's. Here you see ethical concepts, some core concepts. Non-maleficence, or to avoid harm. In this context, it would be providing the safest diet, so maybe a texture-altered diet. Beneficence, or to prevent harm. In this context, it would be providing a preventative diet, so maybe the Mediterranean diet. Justice, fair, equitable treatment, maybe a cultural need could be accommodated into the diet, and then autonomy, or a freely chosen pathway, and that would be including preferences. And as we move through the talk, we'll see CMS puts a lot of weight on including preferences. Maleficence is harm, and in this context, it will be forcing a diet and excluding preferences. A word about competency versus capacity. It all depends on who is deciding. So competency is decided by the court. The person has to be capable of making all decisions and understand all consequences. Capacity, however, is determined by a physician, whether or not the person is capable of understanding a medical treatment and can make the decision based on the risk. So really it's a big picture item. We need to be looking at response consistencies between interviewers. The person really needs to understand their health status and why the intervention is needed. Can they provide a logical reason for consenting or refusing? The decisions are consistent with prior decisions. So looking back through history and things that they've done in their life. And if they're not consistent, we really need to be including a DPOA in the decision making. And then finally, formal testing, formal cognitive testing, say using the St. Louis University Mental Status Exam or SLUMS, can provide a very good indication and part of the puzzle, but it alone is not enough. What is person-centered care? Well, CMS defines that as focus on the resident as the locus of control and support the resident in making their own choices and having control over their daily lives. So this is in regards to all factors of their living. Patient rights focus on the dignity and respect of the resident, incorporate resident preferences into care plans, values the resident individuality and input, and honors the refusal of any treatment and determines residents may not be treated against their will. And as we'll see, a medically prescribed diet is a medical treatment. A word on personalized meals. CMS is specific that meals must incorporate a resident's needs, preferences, and goals. It needs to be palatable, attractive, and nutritious, align with the functional capability, which could require a person to need a texture alteration. Medically prescribed diets are medical treatments, and residents cannot be forced to eat an altered diet. Liberalized diets, a restrictive diet, first to understand, is one that's altered by food type or texture. So examples would be a diabetic diet, a low diet, mechanical or puree, or thickened liquids. These are often prescribed in many facilities. They really shouldn't be. And the reason is that they may increase the risk of anorexia or weight loss in older adults. In 2013, CMS came out with interventions for weight loss, and they talk about liberalizing diets. So weight loss in older adults is associated with muscle loss, decreased function, and death. in a large study of performing more than 10,000 rapid geriatric assessments in acute settings, outpatient, and in nursing homes, it was identified that more than 1 in 3 residents are at risk for weight loss. Some of the tags that come along with not including resident preferences can go from mild to very severe, and 2 of the top more severe examples that were provided in the Surveyor Handbook Guide are listed here. So an altered diet provided against resident preferences resulting in severe weight loss and irreversible functional decline is considered a level 4 infringement. So that's immediate jeopardy to the resident's health or safety. And then failure to incorporate resident food preferences resulting in significant weight loss and functional decline is a level 3 or actual harm. Diet waivers. The takeaway for diet waivers is that they're unenforceable in a court of law. They really should not be used. They're considered an act of defensive medicine, and they really do harm the patient-provider relationship. So I prepared a couple cases just to go over some points, and these are actual people that I took care of. The first one here is a 72-year-old Black female. She's full code. She's had a stroke. She's got some vascular dementia. She had a recent slums exam of 13 out of 30. She has some poor dentition. She's waiting for an appointment with her dentist to have extractions made to make dentures. She was noted by the speech therapist to have dysphagia and a recent swallow decline on her bedside swallow. So the therapist reached out to the daughter, who's the MD-POA, a few weeks ago and asked for a downgrade permission to puree, and the daughter agreed. And so I came into the facility later and she found me very upset, and she wanted to know who changed her diet. And she explained to me how she was sad in the dining room that she had to sit across from other residents who were able to eat real food while she had to eat baby food. She tells me she can chew just fine and she wants her diet back. So what should be done here? The intervention, of course, was to upgrade the diet back to mechanical soft. We had to document, and when I say we, it was myself and the speech therapist who went in together. We documented on the risk counseling that we provided and the alternatives that we provided. You must provide alternatives. It's in the guidelines. And if you don't document it, it wasn't done. She was counseled on her right to refuse care, and that was probably the most important thing that came about. What went wrong here? Well, the diet was not changed when she requested. The underlying problem is that the MD-POA role was completely misunderstood. They cannot override a resident's wishes if they have decisional capacity. And her big picture was that she did have capacity. She had a reasonable slums exam, greater than 10. So when we look at decisional capacity and we're looking at that slums as an indicator, if you're under 10, say 9 and under, that might provide some supporting evidence that a person doesn't have the ability to make a decision. But she did, and she could provide a consistent message to multiple people that she wanted her diet back. The ethical problem here that occurred was lack of autonomy. So how it related to the 4 M's, she wanted real food. That's what mattered to her. And for her, this was a matter of dignity. So the dignity aspect touches back onto resident rights. Mentation, so she had anxiety because of having to eat a diet she didn't like. And dementia wasn't really a factor in this case, even though she had it. So a second case, this is an 82-year-old white female. She was do not resuscitate. She has severe dysphagia. She's been on thickened liquids for a while. She eats scant amounts of food in the dining room, and she's supplemented by a feeding tube bolus feed that she gets. She's had multiple hospitalizations for aspiration pneumonia. Her advanced dementia makes it hard to make her needs known. Her son's been acting on her behalf as MD-POA for the past year and making decisions. So repeatedly, she has come to staff asking for her coffee. It's multiple times a day. And It's been occurring over months, and she won't drink the thickened coffee that they provide her. And they finally get a hold of me, and they ask what can be done, because it was very persistent behavior. So what should be done? What we did was we called the son, who is the MDPOA, and he okayed the thin liquids to be put on her diet order. We had some counseling on what the aspiration risks were. We talked about code status and how if she was going to be wanting something that was outside of the realm of what was recommended medically, what did he want to have happen if something occurred? Did he still want her to go out to the hospital every time? And the answer was no. He opted for a code 3, which is do not hospitalize in our facility, which aligned with the goals of care. So what went wrong is that her preferences weren't included. This is despite having advanced dementia. So she had a preference. Everybody knew what it was. She didn't have decisional capacity, so ethical problems maybe not officially occurred, but something needed to happen. What mattered to her was her coffee, strongly, and it was a quality of life matter for her. So she didn't have mental capacity to okay, so the MDP had to step in, and that's how it relates to the 4 M's. And our last case, she's a 78-year-old white female. She's full code, dysphagia. She's had a number of aspiration pneumonia episodes. She's got some dementia, pureed diet. She has a corticoid guardian, and she's lost 6% of her body weight in the last 3 months. So her diet was downgraded several months ago after a hospitalization for aspiration pneumonia. And she's been complaining ever since to the staff how she can't eat her puree diet, that she has no appetite, she can't bear to eat it, and she wants her food back. So the staff say now she's isolating to her room. She won't come out of her room. She hasn't gone into the dining room lately, and they want to know what can be done. The intervention was to include someone to perform a St. Louis University mental status exam, which they did. It was our social workers who does it in our facility. Her score was 20 out of 30, so not bad. Her guardian was informed of her being able to make the big picture of decisional capacity. So she had a consistent message, and it was previous with previous interviewers from multiple staff members. So we told the guardian that she was able to make decisions, and we counseled the guardian on the aspiration risks. And when I say we, again, it was myself and the speech therapist who sat together on a conference call. And she agreed to the diet upgrade back to her mechanical soft diet. So what went wrong here is that she was forced to eat the diet, and it resulted in significant weight loss, which CMS sees as actual harm. So really what happened here was maleficence. That's the ethical dilemma. How it related to the 4 M's, what mattered to her was food, and it was quality of life. She was depressed, I think. That's why she was self-isolating. But a person could make a case that maybe she had some sarcopenia, so maybe some weakness because of her weight loss. When older adults lose weight, they lose more muscle and bone in proportion than younger people do. So we were headed down a bad pathway. So we're glad that we caught it at this point. So the ultimate story here is that everyone has the right to refuse a treatment. We really have to look at capacity. And so assessment of decisional capacity must occur at the time of the refusal. And if they have the capacity to refuse, simply document and move through the rest of the model that you see here. If there's a suspicion that they don't have decisional capacity, then that's when we need to act, and at the time, not weeks later. So counseling needs to occur. So we need to understand the risks. We need to understand the alternatives. We need to understand the context of the person and their goals of care and what's important to them, specifically what matters. and looking at other things. So if it wasn't documented in the chart, it never happened. We know that. And then everybody who's a pertinent decision maker really needs to be notified. So the provider, all of the staff, the family, and the resident. And then the care plan needs to be updated. So this is the end of the presentation, and here are my references. And if anybody has any questions or further thoughts on the subject, you're welcome to reach out to us at the Gateway Education Center that you see listed here. Thank you.